Morning. I'd like to thank the Allied Professionals Committee for inviting me to share our Irish experience with you guys this morning. Oh, there we go. So I'm just going to talk about how we developed an outreach service to set up non-invasive ventilations for our patients and thereby averting hospital admission. This is just a map of Ireland. Ireland is divided into 4 provinces. We've got Ulster, Leinster, Munster and Connacht. Ulster is part of the United Kingdom, and Connacht, Munster and Leinster make up the Republic of Ireland. We have a population of 4.95 million. It's 300 miles from north to south and 150 miles from east to west. I'm based in Dublin in the clinic, which is led by Professor Orla Hardyman, and we would see about 80% of the Irish population with ALS in Beaumont. We have 110 new cases each year. 300 patients are living at any time with motor neuron disease in Ireland. 15% of our population have a familial form of ALS, and 70% of our patients die within 1,000 days. So these are just some of our studies. I'm very fortunate to be part of a very extensive ALS multidisciplinary clinic, and listening to some of the previous speakers today, we're very lucky that we actually have access to neuropsychologists, and our patients are assessed using the ECAS at the clinic when they come to see us. We have access to dietitians, speech therapists, occupational therapists, physiotherapists, palliative care, spiritual care. We very closely work with the respiratory physicians. As I said, we have neuropsychology. We also have there's 2 nurse specialists working with the Irish Motor Neuron Disease Association, and they attend the clinic as well, Ethna and Fidelma. And that's a very useful service for our clinic, because if patients are identified as having certain needs, be it a bed, a suction machine, lifting and reclining armchairs, our healthcare professionals can request them that day. We're also very fortunate that the association in Ireland provides eye gazes. So sitting and listening to people talking already, I think we're in a more privileged place than some people are. So the background to our change in practice. I don't think it's any surprise that we've been struggling financially in Ireland, but we're getting better. And the recent changes in the Irish healthcare delivery system, in particular the difficulties in arranging timely hospital admission, have resulted in a shift of patients needing increasing acute care in the home setting. So the decision to initiate an outreach service to set up NIV was a direct result of the ongoing delay and actually sometimes failure to arrange timely admission for people with ALS identified respiratory problems. So we were seeing people in the clinic, and we were identifying their need for respiratory support. They were put on the list for admission, but sometimes it was taking as long as 3, 4, 5, 6 months, and people were running into some problems, and some people had died before we'd actually admitted them. So we needed to look at what we were doing. We know that respiratory muscle weakness is an independent predictor of quality of life in ALS, and respiratory failure is the most common cause of death. Respiratory muscle dysfunction results in impaired gas exchange, particularly at night, with symptoms of carbon dioxide and retention, including sleep disturbances, morning headaches, and fatigue common. And it is associated with dyspnea, impaired quality of life, and shortened survival. So with all that in mind, when we see our patients in the clinic, these are the symptoms that we look out for when we ask about dyspnea on exertion or talking, orthopnea, nocturnal awakenings, excessive daytime sleepiness, daytime and morning fatigue, difficulty clearing secretions, morning headache, nocturia, depression, poor appetite and poor concentrations. These are often signs of that patients are beginning to run into problems from a respiratory point of view. And the signs there, I won't go through all the signs. So non-invasive positive pressure has become the standard treatment for patients with respiratory insufficiency. And the bi-level intermittent positive pressure ventilate imitates the physiological function. It's triggered by the patient's inspiratory effort, reduces the work of breathing, and it improves gas changes and sleep quality. This is why we're using it. NIV used in patients with early respiratory muscle involvement who are compliant and without severe bulbar dysfunction has been shown to extend survival and improve quality of life. We have a patient at home, he's the longest patient on NIV, and he's heading into 5 years on 24 hours a day on NIV. I think there's considerable evidence that patients can survive for many years with 24-hour NIPI, particularly when techniques are used to achieve adequate clearance of secretions. I'm not going to talk about the support that we have from a secretion point of view because Rachel, our physio, is here and she's going to talk about the adjuncts that we use in airway clearance in her speaking after me. So basically what happens, people come to the clinic and we'll take referrals from everywhere, and that's why we see 80% of the population. Sometimes we're seeing people for the first time. What happens in Ireland as well, most neurologists around the country will recommend that the patients register with the Irish Association. So when they've registered with the association nurses, as I said, and Fadama, the two girls will call out and make contact with the families. Now, sometimes they will go out and they will find people who actually may be in an advanced stage of their illness, and they will refer them into the clinic. This often means that we're actually seeing people who may be at a progressive stage. We like to see people in our clinic every 6 to 8 weeks. But if they've found somebody in the community that hasn't been attending a clinic, we often get people that are in trouble. I mean, sometimes we've set up NIV that day in the clinic because people are in trouble. So it does really help. But the test that we're doing, again, we're very fortunate. Rachel, our physio that's going to speak, is one of our physios who assesses respiratory function. So we do a sniff nasal inspiration pressure, maximum, the MIP, the forced vital capacity. If patients are in, we'll do arterial blood gases. We do a peak cough flow, and we'll do pulse oximetry at night in the patient's home. The criteria that we have for setting up NIPI is if there's significant clinical evidence that they're having the symptoms of respiratory failure. If we have a SNP measurement of around 50, that's a good indicator for us to start thinking about using NIV. And if we use, listening to the symptoms that we have, and we sometimes send people home with a pulse oximeter, we can see that their oxygen levels are dipping. They may be reporting to us that they're waking up at night, but often it's a sign that the oxygen levels are dipping. So it's a combination of all of these things that lead us to start using NIV. So it's usually prescribed by the neurologist or the respiratory consultant, and we tend to use the settings of an inspiratory pressure of 12 and expiratory of 4. Now, I know in Belfast they use much higher settings. We tend to keep the settings at that level, and while we monitor patients on the NIPI when they're at home using the pulse ox, if the oxygen levels are dipping and we need to change them, we found that often changing the settings means if patients have managed to tolerate the machine, that if we change the settings, that it can interfere in their ability to tolerate it and actually may cause more problems. So there's very close collaboration between our team, the pulmonary function department, and Respicare is the company who provides the NIPI machine for us. Once we've identified people. Now, we're very lucky in that if I see somebody at the clinic and they're prescribed NIPI, I can ring Lisa, is the girl that I work close with in Respicare, and we may even be the next Monday or Tuesday be setting an NIV up. So depending on the needs, it's a fairly rapid service. In recent times as well, not only have I gone into people's homes to set up NIV, but I've set it up in other hospitals. If they've been referred into our clinic for referral, I've been invited into hospitals, nursing homes, to set up NIV. So as I said, we need to do ongoing assessment regarding the use and the settings of NIV, and they're carried out at home. And depending on the analysis, we'll adjust if required. But oftentimes, as the person progresses to end stage, it may look as if they're struggling, but it's quite interesting to see that most people tend not to tolerate when we increase the NIV settings. This is just what's happened. I mean, we started this a number of years ago, but things actually around getting people into hospital and having access. What happens in Ireland is if there's patients in A&E, they overrule elective admissions. So we're admitting less and less people. We're doing less and less gastrostomy, so the number of patients that are actually admitted into hospital is becoming, significantly decreased. In 2010, there was 10 patients set up on NIV at home. And this year we went up to 38. I actually set up 7 people last week on NIV at home, so I'm now turning into the NIPI nurse. But our NIVs are covered by the medical card that people have at home. So we have a medical card system that we've been challenging the government that patients, regardless of need, it's usually based on your financial situation, but we've managed to procure from the government that based on your diagnosis that you will get a medical card, and therefore it will entitle you to access to the services that you can get, including the NIV. It costs about €300 a month to rent it, and the drug refund scheme there is, in Ireland as well, a family will pay a maximum of €144 a month for medication. And if you didn't have a medical card, actually the drug refund scheme would cover you. So if you were on Realitech, you've probably already reached the 144 maximum, so it's not going to cost you anything for the NIV. What does cost is the time. Given the size of Ireland, I could spend 8 hours driving, going to visit a person at home, and the expenses that are incurred is my time and travelling. But where there's a huge financial saving is that to be admitted onto our neurology ward costs about €1,000 a day. And we seem to be very inefficient when people are admitted to hospital. So somebody being admitted for NIV could actually be in for a week. And it's considerable cost. So the advantage of having the fast access, and most people don't want to be in hospital either. I think the advantages of setting up the NIV, as I said, patients are definitely fast-tracked, ensuring that it's timely and appropriate. There's been a huge reduction in the number of hospital admissions, significant financial changes. And I think one of the things that it also provides, if I was going out to set up the NIV, I'd probably get in touch with a public health nurse or maybe the local physiotherapist, and they may not have had experience around using a NIPI. So I can invite them in and we can have an educational session while we're setting up the patient. What tends to happen as well, I think, in the family home is that more family members will come around and they'll get to see you use it. I also think for families, it seems to be less clinical and they're less scared of the machine having it set up at home. So we kind of go in and people will have the kettle on and we'll have a cup of tea, and it's just much less clinical setting the NIV up home. So I think that actually helps people. It would be interesting to see, haven't done it yet, how people who are set up on NIV, if they actually tolerate it and if it quicker and lasts better on it than patients who are set up in the hospital. I have a feeling that they probably are, because I think they're less intimidated by having it set up at home. One of the other things that it helps, we would like to have access to palliative care services quite early in the illness, but due to the lack of resources, our main criteria is definitely once we've identified that you're having respiratory problems, that really is a time when we need to have access to palliative care. If patients can't tolerate NIV, we need the expertise of palliative care to help support the respiratory symptoms that they're having. I think one of the other things that it's really important is that it helps to have a discussion around end-of-life issues. So in order to have a discussion about end-of-life, I think patients need to, at some level, understand that death, while not imminent, is going to be the outcome of the illness. So sitting at home is much less informal, it's less scary for people than being in the clinic. And I think it creates a much nicer atmosphere to discuss end-of-life issues, to discuss what they would like to happen, when they would like to happen, and have their family present. I think it's also very interesting having discussions around end-of-life issues, and to have the community people involved, because then they have a sense of what's been discussed and what hasn't, so they can continue the conversation with the family. It can help around advanced care planning for patients and family. In Ireland, advanced care directives are not legal, so we have the difficulty that some patients may wish not to be ventilated, some may wish to be ventilated, but we've no guarantee that either of their wishes are going to be respected. The other difficulty that we have, this is a non-invasive ventilation. I feel that this is often an opportunity for me to discuss. We have 2 people in Ireland at the moment who have invasive ventilation and tracheostomy. It costs about 300,000 or 400,000 a year to have people at home on ventilation. So what tends to happen is that somebody is ventilated, they'll actually be kept in hospital. And our system is changing in that we now have people who are requesting invasive ventilation, but we don't have the resources to support this. So this is a huge dilemma for us. It's interesting, to see the gentleman on the previous film who was 9 years ventilated. We have a young man as well who's been ventilated, and he's been very fortunate that the government did pay to get him home. But most people will end up spending their time in hospital. We had a gentleman who spent 6 years in intensive care in a local hospital. So these are dilemmas that we have in Ireland. It's probably different for everybody else. So I think, as I said, it gives an opportunity to have these very difficult and challenging discussions, and I think they are sometimes better had at home. So developing an outreach service for NIV may be beneficial to other clinics. I think we need to be looking at our services and constantly evolving. I suppose now I'm wondering, do I need to set up an NIV clinic because it would save me travelling around the country? But actually, I think I might lose the essence of how nice it is for somebody to be at home and to set it up in the kitchen, having a cup of tea and having a chat. And these are just the people that we work with. I would like to thank the patients and the carers. Professor Costello is the respiratory consultant. Lisa is from Respicare, and Shane, the MND specialist nurses, Etna and Fidelma, and the pulmonary function department. Thank you.
Thank you, Bernie. Okay, we do have time for questions here. As well as saying who you are and where you're from, please could I also ask, if you're asking a question, that you stand. We are live streaming the session, so it's important that we can capture you on film. And also, if you could keep your questions quite simple. We do have a number of people here whose first language is not English, so if we can sort of use really simple language, that would be really useful. Thank you. Okay, so questions from the audience, please. Yeah, I've scared you all. Go on, at the front. Rod.
Rod Harris from Motor Neurone Disease Victoria. Bernie, I think one of the key issues before the implementation of non-invasive or invasive ventilation is a discussion with patients about end-of-life decision-making. I have great difficulty in accepting that it's impossible to be able to make people aware that ultimately that machine might be turned off by their choice. And I wonder what efforts are happening in Ireland to actually drive the enforcement of patient decisions in making choices about the removal of treatments and particularly the removal of ventilation.
That's very interesting, Rod. And we would have a discussion in the home around invasive ventilation, and quite interesting, most patients in Ireland don't want to have invasive ventilation because it often means having to be in hospital and they want to be at home. But they don't tend to equate being on NIV and that actually it can continue indefinitely. So we have the dilemma now that we are setting up in people with NIV quite successfully. We haven't had anybody in Ireland yet who's requested to have the NIV withdrawn, which is really quite interesting, although we would have no problem supporting that, and we would have palliative care involved to do that. But interestingly, most of our patients will die actually on NIV with palliative care in place. The bigger dilemma that we have is that people are requesting to have invasive ventilation. And as I said, oftentimes people that are also requesting not to have invasive ventilation, if they ended up in an ambulance going to the local hospital, they may well be ventilated. So the whole purpose of having the discussion around end of life and advanced care, even though they're not legally binding, it means that the family have had the discussion, they have some idea of what the patient wants. I think when you're setting up NIV, it's a useful time because you're identifying that the patient is having problems with breathing, but also you're given something to support them. And if the NIV doesn't work, we can have palliative care. So it's not all or nothing. We're saying you now have problems, we can support it, and we can have a plan in place. And I think that's what's most important.
Thank you. Other questions, please? Okay, I've got one at the front.
It's Jes Rabeck from Denmark. We have the same population as you have in Ireland. And we have also had non-invasive and invasive ventilation for the last 20 years. And today we have around 150 in non-invasive and invasive, half of each. But we also have the helper system. And I think that's the difference, that everybody can have a helper system when they are in invasive ventilation 24 hours, 7 days a week. And I think that's what they need. You can't have invasive ventilation, then you have to be in hospital if you don't have the helper system.
Yeah, exactly.
So I think that's the difference. So it's not something about medical, it's something about social. It's not the other way around, because we can see that half of the patients in Denmark, they choose to have invasive. It's them who do it, because they can choose themselves if they will be in non-invasive or invasive. But it's about the social system, it's not the medical system.
Thank you. We have the dilemma that it's not a choice. And at the moment, there are just under 80 patients on NIV in Ireland, and there are 3 people on invasive ventilation. One guy is a doctor. He's been around for quite a long time and has been quite successful in his career. We have the other gentleman who was funded by the government after being ventilated in a private hospital. And then we have another lady who was ventilated in a public hospital, and she's now heading 3 years into intensive care in the public hospital, and there is no chance of her getting the care package to go home. So.
Is there a final question? Okay, final question.
I'm Pamela Cazzoli from Canton, Ohio, United States. And this was a wonderful presentation, Bernie, and really delighted to see what you're doing in Ireland. Just a question I have for you, because I love your concept of the non-invasive clinic. And your patients that are using bi-level ventilation, are you referring to the bi-level machines that trigger the patient needs to trigger the breath?
Yeah.
Or if that's delivered breaths? Which bi-levels are you?
The bi-level that we use is that the patient triggers it. Now, the alarms are set that if they don't trigger it, that they will kick off, but actually it's the patient that's controlling it. And I think that makes a difference for people. It's interesting when we set NIV up and people, they'll say this is, it's really very hard. And a couple of weeks later, you'll get a call to say, I don't think the machine is working because the pressure seems to be so low, but they've actually just got to tolerate it. But actually the patient is triggering the machine that we use.
Okay, thank you very much, Bernie. Thank you.